Dear students, we'll discuss an image today, which is very commonly kept image in the exam, in Oxy, in Viva. So let's see what is this image is. See that it is the plain X-ray abdomen. You know that plain X-ray abdomen is where diaphragm should be covered, lower chest is covered, entire abdomen up to the part of the pelvis is covered. But plain X-ray KUB is diaphragm is not covered. Where entire pelvis is covered, you can see you have to see the kidney, ureter, bladder. Where penetration is very high, so mainly it is concentrating on the retroperitoneum, whereas plain X-ray abdomen is mainly concentrating on the abdomen. So difference is there. Technical meaning difference is there when you write plain X-ray abdomen or plain X-ray KUB. Plain X-ray abdomen is not equal to the plain X-ray KUB. Abdomen, diaphragm, when you do plain X-ray abdomen, diaphragm should be seen. So your penetration into the intra-abdomen structures, not retroperitoneal structures. That is the difference you should remember when you write a X-ray form actually. So this is typical plain X-ray abdomen, commonly used for emergency situations. To see the gastrointestinal diaphragm, already gastrointestinal diaphragm X-ray image already there in my lecture. You can go through that similar X-ray. I have discussed in detail about that in earlier my brief lecture sessions. Please go through that. It will give a lot of information about the gastrointestinal diaphragm. Whereas here it is multiple air fluid levels. See that in erect posture. This is important in erect posture. Otherwise, air fluid level will not occur. And show the multiple air fluid levels. See that 1, 2, 3, 4, 5, 6, 7, 8, 9. So many are there. So normally there are 2 or 3 air fluid levels. One is normally fundus shadow. Second is duodenal shadow. And third is occasionally cecal shadow. Anything more, 3 or more than 3 suggests intestinal obstruction. That is not normal. So you have to take the X-ray in erect posture. Diaphragm should be seen. And if anything more than that, more number of air fluid levels are the distal obstruction, like ileum or colon. If proximal, more than 3, but not very number, maybe 5, 6. Here it is so many are there, maybe more than 10 are there. Must be it is a terminal ileal obstruction or something. If colonic obstruction is there, you can see with the multiple air fluid levels with the obstruction in the distal part. Colon, dilated colon will be visible in colonic obstruction like carcinoma of stomach, sigmoid volus, or stricture, tubercular stricture or colonic stricture of different causes. So you should be able to see what is the cause, where is the block, obstruction. So depending on the number of air fluid levels. So minimum normal is 2 or 3. Anything more than 3 is pathological. And if it is 5, 6, we say distal jejunal obstruction. If it 10 like that, we'll say ileal obstruction. With the multiple air fluid levels, with the dilated colon, with the obstruction, we say colonic obstruction. That's why that's how exactly will come in. But current trend is ideal investigation. It's a CT, probably plain CT abdomen, clearly gives idea of obstruction, air within the bowel wall, edematous bowel, how many dilated bowels are there, dilated bowel width also it will give, I say how much it is width is there, like in centimeter also it will give full the idea whether it is pathological or normal. So that's why I said CT is ideal investigation currently. Of course, initially we will do the abdomen, then go for the CT. All blood parameters should be done, including electrolytes, hematocrit, LFT, creatinine, and so on. Initially, resuscitation start IV fluid, pass the nasogastric tube, then decompress the bowel, then pass the catheter, central line if you need it, then rule out diabetes, blood tests, all tests that will be done. Give fluid because they will be dehydrated, hydrate them. Important. Then of course surgery is the treatment, laparotomy. Then identify the site of the obstruction, relieve the obstruction, so find out bowel is viable or not. There are different criteria are there. Pulsation, color. If you give 100% oxygen, color becomes normal. Then feel of the texture of the bowel, and different criteria will say whether it is bowel is viable or not. If it is viable, bowel has to be resected and anastomosis is done. If a distal part bowel, if it is not viable, gangrenous, then you may have to do a resection and do a stoma, ileostomy stoma, so that sepsis will be there, recovery will be better, and eventual leak will not be will be prevented. So possibility of leak will be there because it is unprepared bowel and there will be sepsis, the nutrition will be deficient. So you may have to do a stoma for that, which will be closed later after 3 to 6 months. So surgery is the treatment. So what are the causes? Hernia and postoperative adhesions are the commonest causes, remember. Other causes, congenital anomaly, intussusception, malignancy, volvulus, Crohn's disease, round arm obstruction, carcinoma, jejunum, ileum, everything have the different causes. So remember all these causes, detail about intestinal obstruction classifications are given in my book, SRB's Manual of Surgery. Also brief thing about that also given in my clinical book. That also you can go through that. It's extensively management, everything more than sufficient for any students or learner to face the exam. So please go through my manual and Manual of Surgery and clinical methods in surgery for the detailed explanations and learning about the intestinal obstruction. And so in the case again, it may be in the lumen obstruction like roundworm, in the wall, maybe stricture, outside the wall, compression from other area, lymph node compression, whatever it is. So that's how it exactly it is. Again, so many classifications. Go through my book. We'll learn everything about the intestinal obstruction. It is a common main question asked also. Many things will be asked as a short note, like interception is a main question or short note. Stricture is a main question or short note. Wall loss is a question. So the congenital anomalies like duodenal atresia, also a short note. Malrotation is a short note. So different causes of intestinal obstruction can be asked as a short note or main questions. MCQs will be asked for so many. So please go through my surgery topic, intestinal obstruction from Manual of Surgery. And so answer the MCQ. Gilroy B1 triad is seen in interception, obstetric hernia, malignant bowel obstruction, adhesive small bowel obstruction. Student, please put the right answer. I'll appreciate and acknowledge your correct answer later. And another MCQ is upper limit of the normal diameter of small bowel is 3 cm, 4 cm, 5 cm, 6 cm. Put the right answer. I'll acknowledge you and put the right answer later. So this is the quotation of the day, students. Vision without action is daydream. Action without vision is nightmare. So avoid this one. Have a vision and plan an action. Plan the proper action. That's the exact treatment. Especially it holds good for the surgery. Students, please go through my SRB's Manual of Surgery, SRB's Clinical Methods in Surgery, and SRB's Operative Surgery, Surgical Atlas. The new edition has come, and Atlas of Steering Technique. Manual gives everything in detail about all topics as per CBM syllabus: general surgery, gastrosurgery, urology, neurosurgery, cardiothoracic, and basic instruments, specimens, brief operative surgery, which is essential for UGs. Everything is covered with the quotations, with the illustrations, the diagrams, photos, covered everything as for CBM syllabus. And clinical methods in surgery, current edition gives a proper clinical idea, approaches to all cases, briefly orthopedic also. Again, it contains instruments, specimen, images also, and videos. Each chapter videos are there how to examine a patient, which is very important when you do a practical exam, clinical exam. So very, very useful, everything, with again, lot of photos and proper methodology of examination with the differential diagnosis tables are given. So it will be very, very useful. Of course, operative surgery is a very detailed 2-volume extensive book with more than 10,000 photos and illustrations. Whenever you want to, any surgery, including specialty, general surgeries, gastrosurgery mainly, in detail it is given. It will be very, very useful. So students, also go through my SRB's Surgery Insight YouTube Insights, and please subscribe for all these lectures, daily lectures for brief 6 to 10 minutes, and live sessions once a week or once in 2 weeks I am doing. They're also very, very useful for students with with the interaction with the senior faculties are there, and always they can answer your doubts and through chat. So please subscribe my channel, YouTube, Instagram to have a better knowledge and increase your surgical knowledge as such, because it is free also. And my DigiNow lectures through JP, around 220 lectures covering everything surgery, including specialty, operative surgery, clinical methods also, with the videos through JP Publishers. And you can always purchase that one for 1 year, so that you can have go through all lectures, so have a very clear idea about the subject to face any exam, including NEET or final year exam or even PG exams. So students, I hope you understood this image very well. Thank you so much.